Okay. So what do you know about endocarditis prophylaxis? So what do you know about endocarditis prophylaxis, doctors? What are the two criteria that you should fulfill to give endocarditis prophylaxis? Very important. Very important. Yes. Yes, doctor, because I was getting so much DMs asking for this topic. This is actually not a harder part. But you have to remember, and if you can understand the true concept behind it, it is actually easy. But you have to work hard to remember those indications, right? Yeah, that's the only thing I need to remember. Okay. Okay, here. So, this table is the very important, most important table. Very important, right? Actually, so because to before starting the infective endocarditis carditis prophylaxis, everyone, like if someone want to start prophylaxis, that person should meet two criterias. Both criteria should be fulfilled. So what are those both criterias here? Okay, I'll explain. TG. I'll share this part as well. Okay. So here, so antibiotic prophylaxis against infective endocarditis is recommended only for people who meet both the following criteria. That means the one criteria is not enough, right? Both should be fulfilled. So let's see what are those criteria. So undergoing a procedure associated with high risk of bacteremia and subsequent infective endocarditis. So you have a list here. Then so, have a cardiac condition associated with increased risk of developing infective endocarditis. Okay, and the highest risk of adverse outcome from the endocarditis. Okay, and these two chart, this one and this one, you should remember each point because different question they can give like a different way. So because of that, these points are not very hard. So you have to remember these things. Okay. Um, so dental procedures. So what are the high risk dental procedures that you have to consider? So only those involved in manipulation of gingival or periapical tissue or perforation of the oral mucosa. Example, dental extraction, implant placement, biopsies, removal of soft tissues or bone, scaling, right? Supragingival or subgingival debridement, sorry, replanting our teeth, right? These are the dental procedure that we are taking under high risk category, right? So all other dental procedure except from here are lower risk, right? Okay, then here, dermatological or musculoskeletal procedure. So what are the dermatological procedure that can increase the risk of infective endocarditis? It is only those involving infected skin structures or musculoskeletal tissues, right? Remember, then respiratory tract or ear, nose, throat procedure. So only for tonsillectomy or adenoidectomy or invasive respiratory tract or ear, nose, and throat procedures to treat an established infection. Example like drainage of abscess. These are the high risk procedures, right? So then the most important one, like AIMS is asking from this part, genitourinary and GI tract procedure. Very important, doctor. Remember, this is the important one because they have asked this in October and this March as well, right? So this is very important because there are some confusion part. That's why they are asking from here. Okay. So, genitourinary tract or GI procedure, if only if surgical antibiotic prophylaxis is required, or here or for a patient with established infection. That means okay, we are planning to do some procedure. Okay, we are planning to do some procedure. If this procedure needs some surgical antibiotics or if at the same time this patient is having some ongoing infection, then only either need surgical prophylaxis. So having ongoing infection at the moment, then we have to think about giving this antibiotic prophylaxis for endocarditis. But only this part sufficient is not enough. You have to find something from this part as well, because both should be present to give infective endocarditis prophylaxis. Both criteria should be given, right? Okay, so remember then, cardiac condition for which endocarditis prophylaxis is recommended for patients undergoing a procedure listed above. So if the patient is undergoing one of these procedure with either prosthetic cardiac valve, including transcatheter implanted prosthesis or homograft, or prosthetic material used for cardiac valve repair, such as annuloplasty, ring and cords, previous infective endocarditis, ventricular assist devices, congenital heart diseases, but only if it involves unrepaired cyanotic defect, including palliative, shunt, and conduits, a repaired defect with a residual defect at O, adjacent to site of prosthetic patch or device, which inhibit endothelialization. Yeah, disease, but only involve one of these. Okay, then rheumatic heart disease. Usually, they are not asking from this congenital part. Usually, either they are given history, they are given patient is having history of rheumatic heart disease, or patient is having prosthetic heart valve, right? Something like that. Or patient is having previous infective endocarditis. I think October question we have got a patient with the infective endocarditis, right? Infective endocarditis. So these are the two things that you need to remember when you are deciding to give treatment for, not treatment, prophylaxis antibiotic for uh, infective endocarditis. So one from here and one from here must fulfilled. Then only we are giving antibiotic. Okay. Then another thing, when we consider about this part, so, what are these surgical prophylaxis? So, only if surgical antibiotic prophylaxis is required. So, what are these? What does that mean? Because there is a huge list for AMC for in therapeutic guideline that they are mentioning. Either this process is need surgical prophylaxis or not. Okay, we'll go. This is that. This is the 1 minute. I'll read this. This is the chart. Okay, here. Can you see this is the surgical antibiotic prophylaxis therapeutic guideline summary. So they have mentioned is the surgical antibiotic prophylaxis indicated or not. They are giving for each procedure separately. Okay, they are giving separately. But usually the AMC has asked only from these uh, urological procedures, right? Right, doctors. Okay, like usually they're asking from a patient is undergoing what? Trans, usually transrectal, right? Transrectal resection of prostate, right? That was the question as I remember in March, right, doctors? Mm-hmm. Transrectal one, right? Okay. And we have transuretral as well. 1 minute. I'll show here. That's urological one. I know you can't remember everything from here, okay? But the thing is, if you are doing an exam in later days, right? Later days, then you will get the recall, right? And especially like they are giving a recall, like if they are giving the same procedure in the later days as well, then you have time, right? Then you can go through if this surgery need antibiotic prophylaxis or not, right? Surgical prophylaxis or not, like that. 1 minute, where was that? It's in the department. Here, prostate procedure, okay? We have transurethral resection of the prostate. Is surgical antibody prophylaxis indicated? Yes, right? Yes. Then we have prostate biopsy as well. Then we have transperineal route and transrectal route, right? So, as I remember, they have asked from this one as well, right? This transrectal one, and I think in the October, they have asked from this transurethral resection part, right? In this time, they ask about transrectal biopsy, not sorry, resection, transrectal biopsy part. But in the October, they have asked from this one, the true procedure, resection part. Okay, here. Well, okay, I'll give a I'm gonna ask something, okay? Okay, there's a patient with past history of infective endocarditis. Okay, past history of infective endocarditis is planning to undergo this transurethral resection of prostate. Okay, patient is planning to undergo this transurethral resection procedure, and patient is having a previous history of endocarditis. This patient is eligible for getting infective endocarditis prophylaxis or not? Tell me now. Tell me now, doctors. Yes, right. Why? Is this patient is fulfilled both criterias? Did this patient fulfill both criterias? So what is both criterias? Mm-hmm. So patient is fulfilling what are the two criterias they are fulfilling here? Previous history of infective endocarditis from one box, then another box. The patient is undergoing the high risk procedures, right? That need surgical prophylaxis. That means patient is eligible for to get in prophylaxis for infective endocarditis, right? That is the main thing you need to remember. It's very easy, right? Is this hard? Is this question is harder? Okay, why this part is very harder? Okay, I know antibody prophylaxis. We'll discuss the choices as well. Why this is very harder? Why this is not understandable? Is it that much hard? I'm just asking. Is that much hard, this part? No, right? It's easy, right? Yeah. Thank you, doctor. It's not a hard part. It's easy. You just need understand the theory behind it. Like, and I want to show something. Okay, don't follow this one. Okay, please don't even think about following this one. Okay, because even like personally, I use this when I was preparing as well, because October exam they have given and we all use this one, because here they have not mentioned very clearly about it. Okay. 1 minute. Genitourinary tract. Yeah, in here, as I remember, they have only mentioned about if the patient is having ongoing infections only, we have to give antibiotic prophylaxis. But please never even think about this one. This is no need. Don't even think. Don't even look at this. Just follow uh, therapeutic guideline. That's all. Okay. So that's only I want to show you, because this wrong. Wrong mean they are missing some very important points like the surgical prophylaxis part. Okay. Right. Yeah, doctor. Okay. Next one. Mm-hmm. Next one, you need to know. Okay, we'll go through this procedure one. Okay, here. Okay, we will take an example as this one. Prostate, not this one, sorry. Here, we'll take as transurethral resection of the prostate. Okay, patient is having history of infective endocarditis and he is eligible for what? He is eligible for the prophylaxis for infective endocarditis, and he's getting is getting surgical antibody prophylaxis. So what is the choice? It's a gentamicin. Okay, keep this in your mind, gentamicin. Gentamicin, remember. Then we'll go back to therapeutic guideline. Okay, then you need to think about, is this gentamicin cover these infective endocarditis coverage? As you have to think about. That's the another, I know that's the another harder parts that you are telling, right? Okay, let's go. Yeah, genital tract infections and procedure. Yeah, the same thing they have mentioned. Surgical antibiotic prophylaxis is required or patient is having ongoing infection. Here, if the regime for the treatment of established infection contain antibiotic with activity against enterococci, just thymine and anti-enterococcal antibody. So that's the oral dose administered 60 minutes before the procedure, and intramuscular dose 30 minutes before the procedure, or an intravenous dose within the 60 minutes before the procedure. Like that. If the treatment of or surgical prophylaxis regime, if the patient is, if the, okay, there's a two indication, right? So one is ongoing infection and another one is patient needs surgical antibiotic. If like either surgical prophylaxis or this undergoing treatment is cover enterococci, then there's no problem. If it is not covering this enterococci, we have to add. Here add, not change, add. They are giving add amoxicillin, right? Amoxicillin, we have to add it either intramuscular, intravenous, so like that. Okay. So now tell me if gentamicin cover enterococcus or not. Tell me, doctors. What do you think? Is gentamicin is having the coverage for enterococcus or not? Tell me. If you don't know, just Google it. Then also you will remember, right? Try to find yourself something. Then the memory will very strong, right? Tell me, doctors. Doctors, I'm asking from you, is gentamicin has coverage for enterococci? What about other doctors? Okay, let's see. Okay, is gentamicin, you should know these things. I want to show, okay? No, right? Yeah, gentamicin is not effective against enterococcus, right? Right, doctors? So, we, if the patient is undergoing transurethral resection and patient is taking gentamicin as surgical prophylaxis, we need to add either amoxicillin or ampicillin, right? That's the next thing they have asked in March, right? That was another thing they have asked in the March, right, doctors? Okay, then if the patient is having hypersensitivity to penicillin, then what we should give? We can give vancomycin, no? Teicoplanin, right? Right, doctors? Simple. Is there any like difficulty to understand this part? No, right? So it's easy. Very simple, right? What do you think? What about other doctors? This is how you have to follow this, right? And like other things as well, if the patient is undergoing dental procedures, then you need to know what? You need to know what doctors. Okay, let's discuss one more thing from here. Okay, if they have given asking from dental procedures. Dental procedure. Yes, yeah, doctor. Because Genta alone is not cover for enterococci because this patient is eligible for endocarditis, right? So in that case, we have to consider this gentamicin, the one the patient is taking. Either it can be for their ongoing infection or for their surgical prophylaxis. If it is not enough for coverage to enterococci, you have to add something, right? That's easy. Okay, we'll discuss one more procedure here. Endocarditis prophylaxis for dental procedure. Here, endocarditis prophylaxis only recommend for patients who meet both criteria, right? Undergo dental procedure associated with high risk. So the same thing that we discuss in the in that chart. Okay, in that chart here. Okay. Here also you can assume patient is having history of infective endocarditis and patient is uh, patient is, let's see what they have given for dental one. Those dental procedures they have. Okay, you can think about okay, you can think about this one, cleft lip and no, not okay. 1 minute. What else? Okay, you can think about this. Okay, patient is having a infective endocarditis, a history of infective endocarditis, and patient is undergoing procedure that involve insertion of dental implant. In that case, do we need to consider about it or not here? Okay. Here, here are undergoing dental procedure associated with high risk. So I'll show again this is something different. Okay. Because the rule, surgical prophylaxis rule only for what? Here, genitourinary tract only if surgical antibody prophylaxis is required or the patient with established infection. For dental procedure here, only involved in manipulation of gingival or periapical tissues or perforation of oral mucosa, dental extraction, implant placement, biopsy, removal, soft tissue or bone, scaling, like those things involved. We don't have to think about in this patient needs surgical prophylaxis or not. It's different, right? Because surgical prophylaxis is not a indication for dental procedure, right? I'm telling we have to give surgical prophylaxis for some procedures, but it doesn't matter when we consider about this eligibility criteria, right? Yeah, doctor, we can go with vancomycin. Have you understand what I'm saying? Here, the surgical prophylaxis part matter here, right? Surgical prophylaxis. But when we consider dental procedure, you have to remember this dental procedure. Either they are like it doesn't matter if they are getting surgical prophylaxis or not, doesn't matter. If any of following surgery, if any of following manipulations happen with one of these criteria, you have to give you have to give the infective endocarditis prophylaxis, right? So don't always go with this surgical prophylaxis. It's only for genitourinary tract and GI tract procedures, right? Right, doctors? I hope you understand what I'm saying. Because otherwise, you will feel like in every cases you have to think about surgical prophylaxis. Not right. Mm-hmm. Yes. And here, oh, okay, this is my patient. Patient is having a previous history of infective endocarditis, and patient is undergoing some dental extraction. Is this patient need antibiotic prophylaxis for infective endocarditis or not? Is this patient need antibiotic? Need, right? Because here, dental extraction, you can see dental extraction, one criteria is fulfilled. Then patient is having previous history of endocarditis. Two criteria are fulfilled. Then you have to give the endocarditis prophylaxis, right? So here, what we can give for dental procedures? Okay, we can give amoxicillin. right? If the patient is having non-severe hypersensitivity, we can give cephalexin, right? And for patient who have a severe immediate or delayed like severe hypersensitivity reaction, then we can consider giving doxycycline or azithromycin, right? Consider their potential adverse effect. Then yeah, here doxy or azithromycin. Hi doctors, they are not very hard. What do you need? What do you need, doctors? What do you need actually? You need a small short note for these antibiotics as well, right? Okay, then they have mentioned parenteral antibiotic regime for infective endocarditis. Endocarditis prophylaxis indicated only use parenteral antibiotic if oral is not possible, right? You can patient can present in with not tolerable oral tolerability, like patient is having severe vomiting or something like that. We can't give it with the orally, so we can use parenteral one, right? Intramuscularly or intravenously, we can give. Same thing, and here patient is having non-severe hypersensitivity, we can give cefazolin intramuscularly or intravenously. Like here also, the patient is having severe immediate reaction to penicillin, then we can give azithromycin, right? So like that, you have to remember how we have to give in dermatological procedures, and genitourinary tract we have already done, and dental procedures. And we have something else. What is another one? Respiratory tract or nostril procedure. This is not a harder question, easy question, doctor. Okay. And you all know usually we are giving amoxicillin or ampicillin, right? Penicillin. If the only problem is if the patient is having some hypersensitivity, that is the only problem. Otherwise, we can simply give me sorry for that. Simply give amoxicillin or ampicillin, right? Hope you understand about prevention of the endocarditis. That's all. That's all, doctors. Have you understand? Is everything clear? No doubts, right? Yes. Again, you can't tell, okay? Again, you can't tell, okay? Infective endocarditis prophylaxis is a nightmare. It's a hell. I can't understand. You can't tell, right? Now you should understand. It's not a hard topic. It's an easy one. Okay, we'll do a stroke because I want to show the stroke one is stroke and TIA topic has updated. They have added like acute diagrams because previously we didn't have those diagrams, but now we are having that diagram. Where's that cute diagram? Is this one special? Okay, okay. Let's discuss about stroke. So, what are the features of stroke? So, what is stroke? Doctors, what is stroke? What is happening in stroke? What are the features of stroke? Yes, you can remember it as fast, right? So fast mean what? So fast mean, I'll show here, fast. This is the easiest way to remember the stroke features, right? So F mean face, right? That mean there can be a facial drop, right? Then arm mean. Then what we can see? Patient can have some paralysis, right? So speech mean the patient is having some speech disturbances, right? I Dr. Slurred speech like that. The time that means the time is a critical factor. Time is a critical factor to manage stroke, right? Time is like a golden thing for this one. Like you all know how this TIA, sorry, strokes present. So now stroke and TIA. So now tell me what is the difference between stroke and TIA? What is the difference between stroke and TIA? You need to answer me because you are exam candidate doctors. So what is the difference between? Okay, what is the time? Yes. Usually, TIA is resolved within 24 hours, right? Time is usually less than 24 hours, right, doctors? Time is usually less than 24 hours, right? Yes. Mm-hmm. Yes. Very important. Okay. Very important. Okay. Let's go some overview. Okay. So type of stroke. So what are the? We have ischemic stroke. It can be large vessel, cardio due to cardioembolic, small vessel disease like lacunar infarct, uncertain types, and rare type like dissections, venous infarctions like that. Then intracerebral hemorrhages, and we have subarachnoid hemorrhages as well, right? As well. Okay. Now tell me, I'm not taking too much time for this topic. Now tell me, if a patient present with these stroke features or TIA features, what is the first thing you have to do? What is the very first thing you have to do? Tell me, doctor, what is the first thing you have to do? I have explained these things. Yes, very good. What about other doctors? We have to do non-contrast CD. The first thing. Okay, if you have no idea, just write down. The first thing, what? Non-contrast CT, right? Non-contrast CT. Okay, if the patient is presenting with stroke, we have to do the non-contrast CT. Why? To rule out hemorrhage, right? Rule out hemorrhage. Okay, so what is the next step you have to do? The most next one? The next step. Okay, what are the treatment? What are the drugs? Or what is the procedure next you have to do? What is the next thing you have to do? Immediate treatment is what? Are you sure? Okay, I'm talking about a stroke. Think it as a stroke. What we should do? Next, immediate step is what? What doctors? Okay, just forget A, B, C, D, everything. Like I'm asking, like, okay, think everything has done. So next step of treatment. The first thing we have to do in treatment, what? But okay, I'll show you what is the acute treatment. Thrombolysis, right? Because it's a stroke, right? A stroke. The acute treatment is what? The thrombolysis, right? It could be intravenous thrombolysis or endovascular thrombectomy, right? Right, doctors? Here, immediate treatment for acute ischemic stroke. So, perfusion therapy is time critical. So, establish the time of onset the stroke or the last time when the patient was reported to be well is essential, right? Reperfusion therapy include thrombolysis and endovascular thrombectomy. So intravenous thrombolysis and endovascular thrombectomy should be given together when indication in timely manner. For an overview of the time and perfusion therapy here. So according to the time, we have to consider it, right? Mm-hmm. Okay, here. So stroke onset if it is within 4.5 hours. 4.5 hours, all patients unless contraindicated, we have to give intravenous thrombolysis. Very important. Very important, right? Intravenous thrombolysis within 4.5 hours, right? Right, doctors. So, what about endovascular thrombectomy? Like, not in all cases we are using this thrombectomy, but here all patients with large vessel occlusion, we can do the endovascular thrombectomy till 6 hours. Here, can you see till 6 hours, right? Mm-hmm. Okay, remember this point. Then, if patient come in with 4.5 to 9 hours, then patient with salvageable brain tissue evident on the perfusion imaging. Uh, Sorry, here 4.5 to 24 hours. Okay, 24 hours. We have to identify patient with salvageable brain tissue evident on the perfusion image. And then consider on a case by case basis with the specialist input, right? But patient is presenting with like between usually less than 4 point 4.4 hours, think about intravenous thrombolysis, right? Very important, doctor. Okay, next, this part. All patients with large visual occlusion and salvageable brain tissue evident on the perfusion imaging, right? We can consider about endovascular thrombectomy from 6 hours to 24 hours, right? 6 hours to 24 hours. Right, doctors? So that is the perfusion therapy. Like, always remember about the perfusion therapy as the next thing you have, reperfusion therapy as the next thing you have to do. But you have to always consider about the time. Time is a critical factor in stroke, right? Okay. Next, what we can do, doctors? Next, what we can do? Next, what we can do? Next, what we can do? Next, we can consider what? Okay. Secondary prevention. Okay, but in acute cases, uh, yeah, especially we have to give antiplatelets, right? Very important, antiplatelets, right? Antiplatelets is the next thing. Remember, okay? Because like other secondary preventions, that's depend on the case by case, but antiplatelets, we are like if only there's a if patient doesn't have any contraindications, we have to give antiplatelets, right? Very important, doctors. Okay, here. Where's that part? We have, okay, we'll go through this chart. Okay, overview management of for patient present in a suspected stroke or TIA. So patient present with suspected stroke or TIA, then are the symptoms ongoing at time of presentation. We have to consider at the presenting time these symptoms are ongoing or not, right? What is in the chat? Okay, okay. We will discuss Dr. Abab. You should know, right? Don't ask me like it is single or dual antiplatelet. You know the indication, right? So why you are asking? You have learned this part multiple times, right? So I'll discuss, okay? You don't have to ask, right? Yeah. Okay. So the other symptoms ongoing at time of presentation, present or not, right? So if present, this is an emergency. Urgently transfer patient to the hospital via ambulance or for assessment, right? So transfer hospital with the acute stroke unit capable of delivery and reperfusion therapy. Then urgent assessment needed, including imaging and testing for the investigation of stroke. If a stroke is suspected, if it is yes, treat the acute stroke, then consider acute stroke. So consider reperfusion therapy and other things, secondary prevention part. Not actually antiplatelet is in secondary prevention and acute management as well. Okay, here reperfusion therapy, antiplatelet therapy, neurosurgery, and supportive care. Right? Okay. If stroke is not suspected, consider stroke mimics, right? And you should know about this stroke mimics as well. I'll show here. So these are the stroke mimics, okay? Remember, acute drug side effects like extrapyramidal side effect with metoclopramide, Bell's palsy, brain abscess, drug poisonings, electrolyte abnormalities, ethanol intoxication, functional neurological disorders, hypoglycemia or hyperglycemia, metabolic disorders, migraine, peripheral vestibulopathies, because these all have the same features like this stroke, right? So you have to consider those as well, right? Here you can exclude them. If the stroke is suspected, no, then we have to consider about the mimics, right? Then if we find out there's, as example, there's some Bell's palsy, you have to treat accordingly. Okay, here. At the same time, sorry, 1 minute. Sorry for that, doctors. Still, some flu symptoms with me. Nasal congestion when I'm talking. That's the problem. It's fine. So here are the symptoms ongoing at the time of presentation. If it is no, then urgent imaging and investigation needed to assess likelihood of stroke. Assessment is more urgent if symptoms have resolved in the last 48 hours, or if there have been multiple episodes in last 7 days. Very important. Right, recently they are asking about these questions. Like 2 days ago, patient is having this facial paralysis, right? Like that. So you have to always think about, even though the acute presentation, the symptom is not present, you have to do the imaging as the initial thing, right? Is TIA suspected? Is TIA suspected? If it is no, then again you have to consider mimics. If it is yes, then we have to manage, right? Manage TIA with antiplatelet therapy, right, doctors? Antiplatelet therapy. Then you have to start the secondary prevention. Under that, you have lifestyle modifications, antiplatelet, anticoagulant, BP lowering, cholesterol lowering, and calorie stenosis also you have to manage, right? If symptoms reoccur, yes. If symptoms reoccur, advise the patient to present the emergency department immediately, right? Immediately. Okay. Then the another most important part when we discuss about antiplatelet. Okay, antiplatelet we have. Okay, I'm asking when we are giving dual antiplatelet therapy. Okay, are we giving dual antiplatelet therapy for the stroke? Very important, doctor. Are we giving dual antiplatelet therapy for the stroke? Tell me, doctors. Yes, you should know something here about antiplatelet therapy. Okay, antiplatelet therapy. I'll explain. Yeah. And I think everyone know about contraindication for thrombolytic therapy, right? Is everyone is aware about thrombolytic therapy, right? Is everyone aware about thrombolytic therapy? Sorry, contraindications. Yes, right. I'm not taking too much. I'm not taking time for that. Okay, that's a like usual thing. Okay, here. Yeah. Okay, antiplatelet. Use of antiplatelet therapy following ischemic stroke or TIA reduce the risk of early recurrent thromboembolic stroke. Additionally, antiplatelet therapy may reduce the neurological deficit and risk of disability and death, right? Is antiplatelet therapy is recommended for all patients following ischemic stroke. Okay, here all patients. It's recommended for all patients following ischemic stroke or TIA unless cardiogenic cause is found, like atrial fibrillation, right? In this, in the case of ischemic stroke, if the patient has received thrombolysis, withhold aspirin for 24 hours and do not give antiplatelet therapy unless brain image exclude the intracranial hemorrhage. Do you understand about that? Do you understand it? Yes, right? Here. If the patient receive IV Altiplast, you have to withhold aspirin for 24 hours, right? Right, doctors? Yeah. Then, in case of yeah, then do not give antiplatelet therapy until brain imaging exclude intracranial hemorrhage, right? We know that. So, antiplatelet therapy typically consists of loading dose followed by ongoing low dose treatment. Treatment can also include period of initial dual antiplatelet therapy. Dual antiplatelet therapy with clopidogrel and aspirin is more effective in preventing stroke recurrence than aspirin alone in the first 3 weeks after TIA stroke. However, it has a higher bleeding risk than single antiplatelet therapy. Because of that, we have to use this dual antiplatelet therapy only in high risk cases, right? Otherwise, we are suggesting the monotherapy, right? Monotherapy is enough, but in some cases with high risk TIA, we have to think about giving dual antiplatelet therapy. So, single antiplatelet therapy is usually preferred for patient with moderate to severe bleeding risk after acute ischemic stroke. A higher bleeding risk is associated with large infarct size on imaging and other coexisting bleeding risk.
Yeah. Then, so single and plate therapy include you can give aspirin 300 milligram orally. This is as a loading dose and it can followed by aspirin 100 or 150 orally daily or clopidogrel 300 or 600 milligram orally once and as a loading dose and you can followed by clopid 75 milligrams orally daily, right? Okay, so dual antiplatelet therapy here. So I'll show this part because in TG they have not mentioned about it. Okay, because okay, this for high risk TIA. So how we should understand is this a high risk or not? There's a classification, not classification. There's a tool ABCD2 rule. ABCD2 rule, right? You should remember each point in this ABCD2 rule. If you have done already, even this question you are comfortable with, you are like very familiar with this question, right? So ABCD tool, right? So A mean age 60 years or older, patient is getting 1 point. Blood pressure. If it is systolic and more than 140, equal or more than 140, patient is getting 1 point. Diastolic equal or more than 90, patient is getting 1 point. Then clinical features, any unilateral weakness, patient is getting 2 points. So speech impairment without weakness, patient is getting 1 point. So the duration. D mean duration. So first D duration, that means 60 minutes or more, 2 points. If it is 10 to 50, between 10 to 15 minutes, 1 point. So here, diabetes, if the patient is another D is patient is having diabetic mellitus, patient is getting 1 point. So overall, we have to count the total score, right? If this total score is more than 4, we are categorized this patient is as high risk patients. And if it is equal or lower than 4, the risk is low, right? Very important. Then this is the question, I think. Yeah, this is the question. According to this ABCD2 rule, if the patient we consider high risk, we have to give dual antiplatelet therapy. Aspirin with clopidogrel start within 24 hours, then continue for 21 days, right? Then switch to single antiplatelet therapy. Here we'll do this question. 75-year-old man present to the ED with history of 30 minutes episode of difficulty speaking that occurred yesterday. During the episode, he knew what he wanted to say but could not produce the word clearly. The comprehension was intact. She has had no further symptoms. His speech is now normal. He has type 2 diabetes and hypertension, but reports poor adherence to prescribed treatment. He does not take any regular medication reliably at present. He does not smoke and live independently. There has been no recent travel on examination. He appears well. Pulse rate is 75, BP 160 by 98, respiratory rate 16, SpO2 98. Yeah, in Romeo and temperature 36.8. There is a cause mid systolic murmur over the upper sternum that does not radiate to the neck. Neurological examination is normal. Non-contrast CT brain shows no acute hemorrhage with the dilated ventricle and classified caries cipher. Electrocardiogram shows the sinus rhythm. So what is this? Calculate this one. Calculate this. So, what are the points that we should consider here? So, what are the points we should consider one by one? Tell. Age. Okay. BP. Here. Here. Age more than 61. BP. How much in this patients? 160. It's more than 140. Then diastolic 98. Then here you have 3 points, right? Then patient is having what else? Other than this, patient is having diabetics as well. Okay. Then 4 points. Then what about duration? Duration 30 minutes. 30 minutes mean another 1 point. So 5 points. What else is patient is having in unilateral weakness? 1 minute, want to say. Anyway, now patient is having 5, right? Mm-hmm. Yes, total 5 points. So patient is eligible for this dual antiplatelet therapy, right? Here, in that case, you have to give aspirin plus clopidogrel, right? Yeah. Yes. Then six if unilateral weakness, right? Yeah. So the same thing they are mentioned here. Let's see how much the patient is here. Total five, right? You are correct. Right, doctors? Here, you have to start the aspirin and clopidogrel within 24 hours and continue for 21 days for high risk TIA. Then you have to, after 21 days, you have to continue single aspirin therapy, right? Single antiplatelet therapy. Right? Hope you understand it. Right, doctors? Okay. Okay, right. Okay, so when to give oral anticoagulations? Oral anticoagulants. When to give these oral anticoagulants? So, DOAC, apixaban, rivaroxaban, or dabigatran or warfarin is used for secondary prevention of stroke to a patient with atrial fibrillation, right? Atrial fibrillation. A stroke may have occurred in a patient with a known AFib or maybe in the first manifestation of previous undetected AFib, right? So, if the patient is having atrial fibrillation, you have to think about giving DOAC, right? Right, doctors. Even for like, if you have remember, uh, with patient presenting with atrial fibrillation, and anyway, we have to give the DOAC for to prevent the future strokes, right? If a patient is having a previous atrial fibrillation, right, we have to think about starting DOAC, right, doctors? Yeah, that's another topic. I'm not going to discuss it now. So for now, if the patient is having AFib, you have to think about this one. Okay. And here the best time to start anticoagulation after ischemic stroke is not known. A start or restart anticoagulation if indicated immediate after TIA or minor stroke, 48 hours after moderate stroke, 6 to 7 days after major stroke, right? If anticoagulation is delayed, antiplatelet drugs should be used in the interim, but stop when anticoagulation is established, right? Okay. Then next one. When to use BP lowering drug? So raised blood pressure is the main reversible risk factor for first and recurrent stroke, right? So lowering blood pressure reduces the risk of recurrent stroke and cardiovascular event by approximately 30% per year, right? In all patients after acute phase of stroke or TIA, yeah, all patient here TIA, start treatment to lower blood pressure, right? Aim for systolic blood pressure less than like between 120 to 130, right? For all patients. But anticoagulation is not for all patients, right? It should be associated with atrial fibrillation. So next one, what about statin therapy? Are we giving for all patients? Are we giving statin for all patients, doctors here? Because this also a March recall right here. Lowering cholesterol reduces the risk of ischemic stroke, we know. Then start lipid lowering therapy with statin early duration hospital admission in all patients whose stroke or TIA presumed to be due to atherosclerotic disease, regardless of the patient's lipid level. We should not consider the lipid level, but we need to have some suspicious that actually from atherosclerosis disease. Then we have to give all the patients, right? If we are suspecting, it's the origin, the cause due to atherosclerosis. But regardless of the lipid level is not a marker for that, right? And additional lipid modifying drugs may be required if lipid targets are not reached within statin alone, right? Okay. The stroke specific low density lipoprotein, or we call LDLC, Target concentration for patient taking lipid modifying therapy is 1.8 millimoles per liter. Right? Okay. So managing cardiac stenosis, this is the another part. How we should manage these TIA patients. TIA patients, doctors. No, sorry, not TIA, carotid stenosis. How we should manage. Give me like what do you know about these patients? Like how the management, like your general idea. Tell me your general idea. Okay, that's the investigation. Okay, the carotid duplex. I'm asking about the management. How we should decide the management according to the. Mhm. Okay, here. Mhm. Yeah. Okay, carotid stenosis. Carotid duplex ultrasound is a first-line investigation to assess for carotid stenosis in patient with TIA and carotid bruit, right? Carotid bruit. Okay, so symptomatic carotid stenosis more than 70% require urgent vascular surgical review for consideration of carotid endarterectomy. The combination of ipsilateral amyloid fuga, no need to read that one, okay? So here TG is mentioned like very small part, okay? But like this is from e-medicine. I have made this note from e-medicine, okay? Very important because you all know e-medicine parts, e-medicine questions are very related with the true real exam questions. So we have to follow it, right? So we have to consider first thing first, is the patient having symptoms or not, right? Because symptomatic and asymptomatic treatment are different, right? Then then you have to consider about the level of stenosis, right? How much it's stenosed or not, right? So first discussing symptomatic patients. Symptomatic patients carry stenosis. If it is between 50 to 99% of stenosis, urgent referral for carotid endarterectomy. Urgent referral. Okay, here current Australian Stroke Foundation guideline, while older studies suggest some benefits of the surgery in asymptomatic patient with severe stenosis, more recent evidence and guideline emphasize that the small absolute risk reduction for a stroke with surgery does not outweigh the perioperative risk in asymptomatic individual. Carotid endarterectomy, because this question like they are giving all the cases, right? But here we need for symptomatic one, carotid endarterectomy is a primarily indicate for symptomatic patients with recent within 3 months of stroke or TIA and ipsilateral carotid stenosis of 50 to 99% with the greater benefits seen in those who with 70 to 99, right? Here, 50 to 99 stenosis, we have to think about urgent referral for carotid endarterectomy. But there's the greatest benefits in 70 to 99 stenosis, right? Ideally performs within 2 weeks of TIA or minor stroke, right? Remember. If the patient is having symptoms but the stenosis is less than 50%, so we can treat it with the medical therapy, right? So medical therapy, what the other things? We have an antiplatelet high statin therapy, then strict blood pressure control, diabetes management if patient have diabetes, then smoking cessation and other lifestyle modification. So next category, asymptomatic patients. If the asymptomatic patients also having less than 70% stenosis, best medical therapy. And this is the most important part. If it is more than 70%, if it is more than or equal to 70%, in asymptomatic patient also, we can consider the medical therapy. We can consider medical therapy. We are going endarterectomy only in high selected cases like low surgical risk, long life expectancy, special vascular assessment, right? Very important, right, doctors? Yeah, asymptomatic carotid artery, like the same thing, you can give it a read. Okay. So, because everything is from e-medicine, not mine, not okay. You can do the characterstenosis questions if you are having a problem. So these are the things. What is happening? Okay, these are the things that you need to remember. I think that's all for stroke and TIA, right? Hope you understand everything. Hope you understand everything. Is there any question? Any questions? All right. Yes, everything is clear, right? Remember about this, like even patient is asymptomatic and having 70 more than 70% stenosis without like with some risk factors or something, then you have to go, you can go with still medical therapy, but patient is low risk surgical or long life expectancy special, we can do the CEA, right? Yeah. I don't know what is happening to my lab. Okay, now what we should discuss. Okay, we can discuss some psychiatric topics. What do you prefer? Do you have any suggestions? Because I was thinking about doing delirium, no, acute behavioral disturbance, acute behavioral disturbance. Okay, delirium also we will do. Okay, we'll do delirium then. But I have one question. Do we need to memorize the antibiotic for the surgical prophylaxis? Not really, doctor. Like not everything, but remember about this. Sorry, gynecology, not gynecological, urological procedures and GI procedures. Because like next time they can ask from GI procedures as well, right? So, but mainly for now, just remember the urological procedures like this transrectal resection and the biopsies, right? So mainly they are asking from either biopsy or either resection. So just remember these two for now. If they are asking in like something else like GI, then like, anyway you are doing the exam in later days, right? So like if they have find out some questions, you will get it. Then you have time, right? Anyway, like if you can, like go through GI and urological procedures, right? Because those are the things that we have to consider when we going with this if infective endocarditis prophylaxis. After surgery, can we hydrocephalus stuff? Hydrocephalus stuff mean what? Hydrocephalus, like normal hydrocephalus. Okay, you're asking me to do the okay dementia part, right? Okay, doctor. We can do dementia. No problem. Okay, so here, delirium. So, what is delirium? What is delirium? What is the delirium, doctors? Usually, delirium is an acute deterioration, right, of mental state characteristic by fluctuating symptoms of impaired attention, cognition, and consciousness, right? Usually develop within hours to days, right? Hours to days. Right, doctors? Hours to days. 1 minute. Okay, here. We have three types of delirium: hyperreactive delirium, hyporeactive delirium, and mixed delirium. So, what are the hyperreactive? The patient has agitations, restlessness, hallucination, or delusion. Hyporeactive delirium, the patient is quiet and withdrawn, right? So, hyperreactive delirium is the most prevalent form of delirium, but is not obvious and often missed, right? Because when we think about delirium, we the always coming in our mind is what the agitated disoriented person, right? But don't forget that there is a hyperactive delirium as well, right? So the patient, the mixed one, patient is alternate between hyper and hypo, right? Patient is having agitation, then next time patient can have um like hyporeactive features, right? Okay.
So delirium can cause the patients and family care a significant distress. So in addition to compare to the patient same age, the patient with delirium is most likely to have a longer hospital stay, be admitted to a residential aged care facility, have a subsequent dementia, fall, or can die as well. Okay. So what are the risk factors for delirium? So what are the risk factors for delirium? So here, risk factors for delirium. So delirium is often triggered by one or more precipitating risk factors, right? So what are those? Predisposing risk factors for delirium include age 65 years or older. Cognitive impairment include dementia. In some cases, dementia may not have been recognized and delirium may be the first indication of a cognitive disorder, right? Remember about age, very important. And if the patient is associated with other psychiatric condition, that can be a trigger factor as well. So problem of alcohol use, especially delirium tremors, right? So auditory or visual impairment, multiple comorbidities, right? The previous episodes of delirium and depression, right? Yeah. So precipitating risk factors in adults. So these are predisposing risk factors. So precipitating factors, acute, especially operations, right? So in elderly cases, if the usually most of the time the post-operative delirium is very common in elderly patients, right? So acute hip fractures, acute organ failures, cardiac events like arrhythmias, heart failures, constipations, some other drugs, right? Hyper or hypothyroid situations, infections, so many triggering factors, right? So many triggering factors. You can see the can be a pain, some discomfort, right? So many things. Okay, they have given like different idea. So you need to know this is the another important part. The preventing delirium in adults, the preventing things. So here, so you have to treat the medical condition, right? You have to treat the medical condition. If the patient is having delirium, patient is suspected to have delirium, so you have to treat the medical condition. Then review drugs for their potential benefit versus risk of harm, assessing the pain and providing pain relief, because pain also can be a provoking factor, right, or triggering factor. So you have to give the pain relief. This depends on the patient's situation, right? Mm-hmm. And promoting healthy urinary and bowel function, supporting and encouraging safe mobilization, especially in the toilet, right? So provide adequate hydration, nutrition, and if needed, assistance with the eating and drinking, encouraging use of and ensuring access to glasses and hearing aids, avoiding medical lines and tubes like catheter, drains. So because like some patients after catheterization also can be like associated with the UTI, then can have delirium, like there can be complications, right? And promoting good sleep practice, right? Providing lightning that approximate of the time of the day. Avoid physical and chemical restraints, closely involved in family. One time in 2025, as I remember, it was in June. I hope you remember. They have asked about these preventative factors, and they have given one option as family support, and another option is quite dark room. Hope you remember that one. Quite dark room. And like this too is having a war, right? Because some doctors are telling it's a family support, and other doctors are telling quite dark room. Actually, it's not correct. We are not we should give a quiet place, but not a dark one. Well lighted place, right? Patient need to have with a good ventilation, good lighting, right? Well light, right? So remember those things, okay? Don't misunderstand. The dark mean dark, right? That also can be a trigger factor, right? Yeah. So quiet part is okay, but dark is dark, right? Then in that question, the answer is family support, right?
Then here providing light that approximate of the time of day, then closely involved in the family care or significant other who can support the patient, right? Avoiding these things. So, and one more thing, I think November, right? Remember they have asked about this one about melatonin. They have given some delirium, some question, and they are asking like asking for the what is asking they're asking something about melatonin like in the options they have given melatonin also as a this preventative factor, but here remember at the time of writing there is insufficient evidence of benefit to recommend any drugs. Antipsychotic melatonin acetylcholinesterase inhibitors are prevent delirium. There's no evidence currently, right? Insufficient evidence. So in that case, we are not marking melatonin as the option because most doctors have marked this as the answer melatonin, but it is not true here. It clearly we have not sufficient evidence for that. 1 minute, I'll tell the question because very important in the exam, you can do the mistakes like that. Yeah, that question was. Delirium recurrence, prophylaxis before surgery. They have given options melatonin, risperidone, visual aids. So, what do you think? Yes, visual aids question, right, doctors? Yeah, visual aids. Here they have good using visual and auditory cues, so providing an orientation board, clock, and calendar. So in that case, the answer is visual aids, okay, not melatonin, right? So these are the tiny mistakes you can do during your exam because I know most of doctors are going with the marked answer and you remember the answer and then go and do the exam. That's not true. Like if you get a question like prevention of delirium, you should go this part, right? This part and find out is there melatonin is mentioned or not, right? Because visual aids also there, so you have two options. In that case, you need to know what are the other options as well, right? You have to make sure before marking the answer, right? That's why the exam week is very important, right? So please be careful about these things. Then how we diagnose this delirium? How we diagnose this delirium, doctors? How we diagnose this delirium? Tell me. Here, how we diagnose, evaluating a mental state in adult, right? So here, information about the changes in patient's condition, behavior, form reliable source. If this is not the patient, ask their significant other carers, identify there is a tool, there's a test, right? 480 test, right? 480 test and confusion assessment method, and there are so many tools, right? We can use. So consider whether another condition could explain the patient's change in mental state like dementia, depression, or psychosis, right? If we're suspecting dementia, we have to check the mental state. Very this also a March recall, right? They have given like after surgery, I think. Yesterday we discussed, but I can't remember now the full question. They have given something like that and asking how you should assess. Assess means they're asking how you should diagnose, right? In that case, how to diagnose. So they have given options as mental state, age, so many things, not so many, another option. So in that case, we have to evaluate the mental state in adult to identify if patient is having delirium or not, right? Like that. Then assessing delirium in adults, we have to check here. Here also history taken from a reliable source, then physical examination may be reveal delirium, then evaluation mental state, right? So we have to do everything if you're suspect because UTI, so those also can be a triggering factor for delirium, right? We have to find out the cause immediately. Yeah, if a UTI suspected be the cause delirium in aged care facility, So what we are doing? Okay, you know how to find out UTI. No, I'm not going to this UTI topic. We already discussed about UTI, everything, right? The culture and everything. Okay. Then we were discussing about diagnosis. Then discuss about the treatment. How we should manage these patients. Principles of managing delirium in adults. Okay, I'm going to ask a question. In delirium patient, okay, I'm just asking a simple question. What is the drug of choice? If the patient need drugs, what is the drug of choice? Is it benzodiazepine or antipsychotics? What do you think? In delirium, very important. This is the most important part that you need to know. You know that point, right? Why? Okay. And there's a one exceptions as well. So what is the one exception? Yes. In delirium tremens, right? No, in delirium tremens, we are using benzodiazepine, right? Benzodiazepine, because like when you see some agitations, confusion, the only drug, like first the drug in our mind is benzodiazepine, right? But you should remember, before starting benzodiazepine for some agitations, you have to make sure it is not a delirium, right? Because like in all the delirium cases except for delirium tremens, we are giving antipsychotics, not starting with the benzodiazepine. So why we should avoid benzodiazepine? Why we should avoid this benzodiazepine in delirium? What's the reason? Why doctors? Mm-hmm. What about the doctors? Yeah, it can increase the further sedation, right? First, the confusion, right? I doubt if the patient is having a fall. This patient can fall, right? There can be a respiratory distress as well, right? Because usually in here, the mechanism is different, right? But in like delirium, except for the delirium tremors, the problem is not in GABA deficiency, right? It's due to some, it can be different. It can be some like brain dysfunction due to inflammation or some toxins or like poisons, so many things, right? So in that case, we are not giving benzodiazepine. We are giving antipsychotic. Why? Because if we give benzodiazepine, that can increase the sedation, right? That can increase the confusion, right? It can worse the delirium, right? It can prolong the delirium as well, right, doctors? Yeah, I hope you understand those things. Mhm. Yeah, ideally prevent delirium, but if occurs, the key principles of management are to identify and treat the cause, right? Because you have seen so many triggering factors, right? And start non-pharmacological management, including measures to prevent delirium. So the non-pharmacological management, we use the preventing part as well. The same thing that we discussed earlier, right? If the pain present, so give some painkillers, right? Like that. Okay, so you have to treat the cause. The first thing is start non-pharmacological management, right? Okay, so if a patient has substitute decisions maker, keep them informed the patient status and discuss the management strategies with them. A patient with a delirium must be nursed in a quiet setting where they can be continuously observed, right? Mhm.
Okay. So, what about the pharmacological treatment? Here, delirium can be deteriorate, be alert to sign to increase agitations like persistently wanting to get out the bed and walk around. If non-pharmacological interventions have not claimed the patient, then consider allowing the patient to wander. Reassure the patient may involve the assistant or family person. So, reassess the delirium diagnosis, ensure all potential causes have been identified and adequately addressed and exclude. Then consider pharmacological management later. Like considering these things, the final step is pharmacological management. This is unnecessary for most patients, but may be required if the patient is significantly distressed or considered to be threat to themselves or others, right? So, what are the pharmacological management we have? Now, tell me, doctors. Here, um, 1 minute. Here, no drug is approved by the this TGA to treat delirium. Although antipsychotics are commonly used to manage delirium, high quality evidence demonstrating effectiveness is unavailable. So, systemic review of low quality data suggests that antipsychotics do not reduce mortality, length of hospital stay, or delirium severity or duration. So, do not improve the cognitive function. Additionally, antipsychotics have significant adverse effect, including aggravation of delirium. Right? We all know antipsychotic has a huge amount of side effect as well. Right? Nevertheless, the clinical experience indicate that may be reasonable to use antipsychotic, right? So here, what are the antipsychotic we can use? We can use this haloperidol, especially olanzapine, risperidone, right? For adults with delirium who have Parkinson disease or dementia with Lewy body, use quetiapine, or quetiapine if oral administration is not possible for adults with delirium who do not have Parkinson disease of dementia, we can use haloperidol intramuscular as a single dose or olanzapine IM as a single dose, right? Here, the single dose of antipsychotic is usually adequate to manage hyperactive delirium, right? So, hope you understand it. Delirium is not a harder topic, right? The delirium tremens is another topic. Okay, we'll discuss that as well. 1 minute. Delirium tremens. Okay, we can discuss it from some questions. Okay, I'll do because that's the easiest way to discuss delirium tremens. It's not a very hard part. Don't worry, I will explain from the teacher as well because it's on the alcohol withdrawal. There's only 4 questions. Okay, we'll do some questions. A 64-year-old man is admitted. This time also they have asked, as I remember, admitted to a Mortabun State secondary to perforated diverticular disease. Moribund State secondary to diverticular disease. After resuscitation, he undergoes an emergency bowel dissection and colostomy, Hartmann procedure. His medical history is provided by his wife and include type 2 diabetes, COPD, depression and anxiety. His regular medications include metformin, empagliflozin, sertraline and tiotropium as required COPD. Then he has an extensive smoking history. 2 packets a day for nearly 40 years and currently smoke. He reports a few beers. He is making satisfactory recovery. But 4 days after the operation, become aggressive, shouting and demands to be left at home. He is oriented to person, but not place or time. He is still requesting intravenous fluid for um, he's still requiring intravenous fluid to slow return of gut function. His vital signs from the morning follows: BP 150 by 90, pulse 120, temperature 37.3, respiratory rate 18, SpO2 96. He has required 30 milligram of endone for pain for the past 24 hours, which is consistent with his previous daily requirement. His difficulty to examine further
given his current agitation, but it is not noted that previously his chest has been clear. His abdomen is soft and non-tender and clean wound and functioning colostomy. Calves soft, non-tender with no erythema or edema, no obvious rashes. Which one of the following is most likely to diagnosis? What do you think? Okay, what about other doctors? Here. Okay, here. The several of following. So other options might be correct and needed to be excluded, right? So alcohol withdrawal best fit in the clinical picture. The symptoms and signs associated with alcohol withdrawal typically start 3 to 4 days after cessation of drinking. So non-specific information has been given, but alcohol consumption in this patient, alcohol usage disorder occurs frequently with the global prevalence of 14%. Okay, here. So, in today, in Australian society, it is reasonable to assumption that make that many members of community consume alcohol or regular basis, right? And that does not necessarily mean to excess. In such circumstances, sudden withdrawal from their normal routine could produce the adverse effect as shows in the patient, including hypertension, tachycardia, confused agitation. So, delirium tremors is potentially life-threatening complications of alcohol withdrawal and requires urgent management, consistent benzodiazepine administration, and thiamine and multivitamin supplementation. Right? Okay. This this question is like less details. Just 1 minute. Because I want to show something. Yeah, also not very important. Okay, we'll discuss from the TG as well. That's easy, I think. I have my note, but can't find it. It's a huge topic. Okay, here delirium in alcohol withdrawal. So most delirium in hospital patients is multifactorial. Okay, we all know that here. So here, in assessing delirium in alcohol withdrawal, consider precipitating factors, particularly infections, anemia, head injury, electrolyte disturbances, or metabolic, or there can be post-surgery, right? Post-surgery and so many things. We know some of these disturbances may be part of refeeding syndrome. So yeah, here. So here, in assessing delirium in alcohol withdrawal, consistent precipitating. Doctors, 1 minute. As I remember, I have a good note. Just give me 1 minute. Then I think you also can easily learn. 1 minute. I have a good note, right, Doctor Rabab? Because as I remember, I made some note for my recall revision. Just 1 minute, doctors. Then you also can easily understand from it. Let's see. Oh yeah, I have the management. That's actually not actually for alcohol withdrawal, like whole topic. It's fine. No point discussing alcohol withdrawal, the full topic, right? I think better we will go with the delirium tremens itself. And this is alcohol withdrawal topic. Okay, it's fine. Okay, we'll discuss like a little bit about delirium tremens. Tell me what are the clinical features of delirium tremens? Delirium tremens. Tell me, doctors.
Okay, what else? Usually, like delirium tremors, when we can see like at time, usually it can see like from 48 to 72 hours from the last drink, right? But can occur till 5 days, right? Up to 5 days, but usually we can see it's between like 48 to 72 hours, 48 to 72 hours, but can up to 5 days, right? Here I'll show here also they have explained it here. See the peak about 48 to 72 hours and wane over 5 days, right? 5 days. Because the delirium tremens part, you have to remember there's a very important thing in alcohol withdrawal. Okay, the features we have, delirium, these things, confusion, disorientation, right? Other than that, the patient is having what? Patient is having tremors, right? Then patient is having autonomic features like tachycardia, sweating, fever, hypertension, right? Do you remember the fever? Because when I was doing the recall revision, some doctors were asking, is there any fever in alcohol withdrawal? Like that, okay? Fever is there, okay? I'll show. Fever is there, okay? Don't be like confused. Fever also one feature in here. Okay. Then what are the other? We can see the visual hallucination, right? We can see visual hallucinations, right? Some associated with the seizures as well. Right, doctors? Okay. Here I'll show. Here patient is having temperature as well. Here patient is having temperature as well. And this patient is having here, overnight, nurse and staff report he has become irritable. This is also after surgery, after 3 days of surgery. Has been telling them that aeroplanes have crashed in his room, right? Patient is having some hallucinations, right? So on examination, he appears diaphoretic and visible tremors on hand and is not oriented to time or place and refuse physical examination. Pulse rate is this, and temperature 38.3 as well. Okay. Doctors? Yeah. These are the vivid visual hallucination, aeroplanes crashing, particular characteristic of this, right? So, delirium tremens. Why? After 3 days, cancellation of the symptoms like visual hallucination, tremor, tachycardia, hypertension, fever. So remember, these are very important things. Otherwise, when some doctors say the fever, they were thinking about what? They were thinking about, okay, fever is there, that can be something else, right? So I'm showing a very important points. Okay, yeah. Let's discuss about the treatment. How we should treat these delirium tremors, doctors. How? Okay, here. What is the treatment options we have? Benzodiazepine. Okay, here. Minute. Here also they have mentioned the same thing. Okay. Benzodiazepines are not a treatment for delirium other than delirium tremors. The one I have mentioned, right? Delirium tremors. Here. Can you see? Very important. If it is not a delirium tremors, we are not going with. Benzodiazepine, right? Benzodiazepine here. Benzodiazepine, yeah, the same thing. Okay, 1 minute. Okay, we have to treat. Okay, so what are the treatment options? Okay. Yeah, this is the overview of withdrawal management because delirium tremens also a part of alcohol withdrawal. So treatment. How we should start the treatment, doctors? SATSCO used in where, doctor? Acute disturbances, right? Don't confuse these things. Very important, okay? So tell me, what is the treatment plan for acute? No. Not acute, okay? I'm also sometimes confused when you are asking questions. For delirium tremors, it's also under acute withdrawal. So mild cases, the supportive care is enough. Okay, I'll show here. In mild alcohol withdrawal is generally responds well to supportive care like calm, low stimulant environment, fluid management, multivitamins, reassurance, symptomatic management, and the treatment for the nausea, headache, and can be managed without benzodiazepine in home setting. Okay, so we can manage with that like normal management, non-pharmacological management, under non-pharmacological management of delirium, right? Mild alcohol withdrawal. Okay, so if it is more severe, okay, if it is more severe means signs of alcohol withdrawal include agitation, sweating, seizures, perceptual disturbances, delirium tremors. These are included. We call it under. We go with under more severe cases, right? Okay. Benzodiazepines are not required for all patients undergoing alcohol withdrawal. Very important. Okay, but tremors we need it. Evidence support early use of benzodiazepine for alcohol withdrawal for patients at risk of severe symptoms and complications, right? So benzodiazepine may also use in mild to moderate withdrawal is predicted because it can be difficult to predict severe withdrawal. So here, this is another important one. Thiamine supplementation is recommended for all patients undergoing withdrawal treatment to reduce the risk of peripheral neuropathy and Wernicke's encephalopathy. Right? So now tell me about the glucose and thiamine combination. So what we should give first? What we should give first, doctors here? Very important. Okay, why we should give thiamine first? Why we should give thiamine first, doctors? Because if the patient is having some sorry hypoglycemia, we have to think about say another case. Okay, this is general knowledge. We have to think about if the alcoholic patients giving glucose, right? So in that case, what is the way, like what's the order? First thiamine or first glucose? Okay, thiamine before glucose. Okay, I agree. So what is the reason? So what is the reason? Why? Okay, why thiamine? Because for glucose metabolism in the brain need thiamine, right? To do the glucose metabolism in the brain need thiamine. If we give glucose first, there's no thiamine at the moment, right? That can deteriorate, right? So in that case, we give first thiamine, then we give glucose. Very important points, right? Don't confuse these things, okay? Yes, that's the reason, right? Okay, very good. Okay, and here remember all patients who are undergoing alcohol withdrawal, you have to make sure that patient is getting thiamine, right? Why? Patient is having a risk of Wernicke's encephalopathy, right? I doctors very important these things. Okay. So here, the same thing, my supportive care, benzodiazepine not for everyone, the same thing in the therapeutic guideline, okay? So what is the goal of benzodiazepine? Reduce the symptom severity, prevent complications, improve withdrawal completion rates. So, choice of benzodiazepine. So, what are the choice of benzodiazepine? What is the first preference? What is the first preference, doctor? It's a diazepam. Here, diazepam is usually preferred for managing alcohol withdrawal because it has a long duration of action. It should be given early because withdrawal escalation during first 24 hours to 48 hours and peaks by 48 to 72 hours, especially in delirium tremors. So diazepam is not recommended for patients with chronic liver disease as childhood class B or C, it has active metabolites that accumulate this patient. Lorazepam or oxazepam can be used instead of inpatient to reduce the risk of sedation or delirium. So midazolam by intravenous or infusion is preferred if rapid but easily reversible sedation is required during the hospital management of acute withdrawal. Example like patient is an emergency in emergency department with a recent seizure and a suspected head injury like that. Okay, I'll show. Here the diazepam. In community resident, yeah, 1 minute, no, not this one. Loading dose. Usually, we are giving diazepam orally, right? And with severe cases, we have to give higher doses, right? Okay. Yeah, and if we need like immediately reverse the situation, we can give IV midazolam, right? That's the thing you need to remember. They have mentioned, but main drug is diazepam. Hope you understand everything about delirium tremens and alcohol withdrawal as well, right? I have explained both together because delirium tremens under alcohol withdrawal topic, right? Right? So very important, doctors. Okay, so you have to keep those things in your mind. So, doctors, we will take a small break. We will start now to 44, 40. Imagine it as 45. Come back at 10 minutes, 55 to 55. Okay. We'll take a small break, and at the same time, you can give me suggestions. Like, especially, please give October, not October, April doctors. I'm considering now only April's doctors request only, okay? Because we need to give priority to them. Please give me options. Like, don't tell me like doctor do high yield topics in May 2025. Give me the topics, right? Because I'm also a busy person. Like, if you need to cover a topic, give me the topic, right? I'm just asking topics, not like high yield topics. When we consider high yield topics in one exam, how can I do that, right? You need to be more specific. When I ask topics, you need to give topics, right? Yeah, like that. Okay. Okay. VT and pulmonary embolisms, we have done doctor so many times. Do you need again to go in that topic or new topics? Because we have done. If you want, I can share the video as well. It's not like very long. It's a easy topic. Okay, it's fine. Like if you have like new topics, because these topics are we have discussed multiple times because they ask many questions. Okay. What about the doctors? Yes, I will share the video link as well. Okay, we'll discuss prophylaxis separately. Okay, what about other doctors? Mediastinal adenitis. Mhm. Mediastinal adenitis. Okay, it's a rare topic. Okay, we have to go through the SBO, It's a very important. That's a very important, like common topic. Like in every time they are giving. Last time, are we Doctor, have you watched that last revision videos? In the Imagine Day, as I remember, I have discussed. Okay, it's fine. We'll go and now take your break. Okay, you can take break till 3 p.m. I'll give a 15 minutes break. Then we will continue like more hours. Okay, don't worry. Today I'm free. Anyway, I can continue. Okay, doctors, let's discuss about DVT. So, what are the risk factors for DVT? So, what are the risk factors for DVT? Okay, doctor. Pulmonary embolism next. Keep your question for pulmonary embolism. Okay, first discuss about DVT. Very important. Doctor, please send this question when we are doing DVT, okay? Pulmonary embolism. Then I will explain. Okay. Tell me, what are the risk factors? We have three things, right? Strong risk factors, moderate risk factors, and weak risk factors. So, what are the strong risk factors? We have fractures of the hip or lower limb, hip or knee replacement surgery, major trauma, spinal cord injury. So, moderate one, arthroscopic knee surgery, hormonal therapy, pregnancy, especially postpartum, paralytic stroke, then previous venous thromboembolism. Then week one's eye immobilization, bed rest more than 3 days, air travel more than 8 hours, pregnancy, antepartum, obesity, and advance in age, right? So, what are the typical features of DVT? Typical features of DVT, doctors. Typical features. So, we have calf pain or leg pain that is persistent, right? Then we have swelling of the leg, may involve entire leg, right? Calf swelling more than 3 centimeter compared to the other side, right? So pitting edema confined to the symptomatic leg, localized tenderness along the deep vein system, dilated collateral superficial veins, non-varicose can see, erythema and worm. These are the typical features, right? Yeah, very easy. Swollen, right? Swollen, painful, like we can see, right? Yeah, okay. Then less reliable variable symptoms, tightness or heaviness of the leg, mild fever may can occur, right? So, important, only 29 of symptomatic patients in primary care acutely have DVT because many conditions mimic DVT, right? Rupture of Baker cyst, hematoma, venous insufficiency, like that. Okay. So assessment of DVT, very important, right? You should know when we go with ultrasound or others. So before that, you need to know what is well score. So well score, that is well score, doctor. You need to know each point because you have to calculate the well score in some questions, right? So 1 minute. Okay, here. So let's go. Active cancer, if present, one. Paralysis or recent blast immobilization of the lower extremity, one. Recent bladder, more than 3 days, or major surgery within previous 12 weeks requiring general or general regional anesthesia, 1 point. Localized tenderness along the distribution of the deep vein system, one. Swelling of entire leg, you are getting like one overall for each thing. Then calf swelling more than 3 centimeter larger than asymptomatic side, pitting edema confined to the symptomatic leg, collateral superficial vein, or previously documented DVD. Each one getting score one, right? Then you have to calculate the total score. Then according to this total score, only you are deciding now we going with imaging first or then something else. Okay. So here, then like overall the DVT well score score is equal or more than 2 indicate that probably that can be DVT. As example, previous history of DVT with swelling of entire leg, right? Then it's mostly probably it can be a DVT is likely, right? Because well score is 2. If it is less than 2, that probably DVT is unlikely. According to this only we are deciding here. So, swollen, painful, and tender or erythematous lower limb. We have symptomatic patient. Then we have to check its DVT likely or DVT unlikely. So this decides according to the Bell score, right? If it is equal or more than to its DVT likely, then we have to do the compression ultrasound, a stepwise compression ultrasound. Then, if the compression ultrasound is positive, then we can confirm it as DVT. Then, if the ultrasound is negative, then we have to do the D timer. Then after D time, if D time is raised, you have to repeat this compression ultrasound at least at 1 week, right? After 1 week, you have to repeat it if D time is raised. If D time is raised, sorry. Then after 1 week, this compression ultrasound is positive, then you can confirm it as DVT. If it is negative, it's not DVT. Okay, if the D time is normal, then it's no DVT.
Okay, DVT unlikely or well score less than 2. Then we have to check D dimer. If D dimer is normal, no DVT. D dimer is raised. Uh, then we have to do what we have to do as a next thing, compression ultrasound. If the compression ultrasound is positive, DVT is negative, no DVT, right? It's not a harder thing. Initially you have to check well score, then you have to do the, if well score is likely to have DVT, then you have to go with the compression ultrasound. If it is DVT unlikely, that means well score is less than 2. You have to go with D dimer first. Then according to the this result, then we are deciding what we should do next, right? If any case the ultrasound is positive for DVT, then we confirm it as DVT, right? I hope you understand the easy things. Then the management very important. So usually uh, the initial treatment first 5-10 days. So most of the cases, most but not every cases, most of the cases DOAC is the first line in most patients, not every patients. Okay, DOAC is the first line in most patients, right? So we have apixaban, rivaroxaban, and you should know when we can give, like you should know sorry, creatinine clearance level that we can use these drugs. Okay, very important here. Creatinine clearance for apixaban 25 or more, rivaroxaban 30 or more, right? Very important, doctors, very important. Then what are the special groups? Because like other cases we can go with DOAC, but we have some special groups, right? We have pregnant cases. In pregnant patients we are giving low molecular weight heparin only. Very important. Warfarin and DOAC is not recommended, right? Because they are teratogenic, right? So, and if the patient is having renal failure or creatinine rate is less than 30, we should avoid DOAC, right? Then in that case, we can use low molecular weight heparin with dose adjustment or unfractionated heparin. We can use any of heparin in case of renal failure, right? Okay. So, if we need to give warfarin, can we start directly warfarin? Can we start directly warfarin alone? Can we start? No, right? We need some what? We need what? We need bridging therapy, right? We need some bridging therapy. Okay, if you need to start warfarin, start low molecular weight heparin, enoxaparin 1 milligrams kilograms twice a daily. Then begin warfarin at the same day. Then overlap until this INR is 2 to 3 for at least 2 days, right? Then if the INR is target level is approached, then you can stop low molecular weight heparin. Otherwise, you have to continue it, right? Because we are not starting this warfarin alone, right? Other than that, we have supportive measures, right? Early walk-in, gradual compression, stockings, mechanical things, right? Avoid long immobility, right? Manage risk factors, right? If cancer associated thrombosis, we can use DOAC or low molecular weight heparin, right? So, massive ileofemoral DVT with limb thread, urgent vascular team review we need, right? Because it's a massive one, massive DVT, right? Okay, so duration of anticoagulation, very important. Before that, tell me what is a provoked DVT and what is unprovoked DVT. You need to know the difference. Very important. You need to know the difference. What is provoked? What is unprovoked? Doctors, tell me what is provoked and what is unprovoked. What do you know about provoked and unprovoked? Very important. Okay, tell me. Okay, you are typing. Provoked mean what? Provoked means simply remember with risk factors. With risk factors. You know what are the risk factors we already discussed, right? We already discussed risk factors, high, moderate, and low risk factors. If a patient presented with one of these risk factor, we call it provoked, right? We call it provoked.
If the patient is having any risk factors, patient is not having any risk factors, then we call it unprovoked, right? Unprovoked, right, doctors? Yeah. Okay. So, uh, so now tell me, according to provoked and unprovoked, how? So, what is the duration for DVT management, DVT treatment? Mhm. If it is, if it is provoked, tell me. Here, the distal DVT that was unprovoked, we can give 3 months, right? We can give 3 months unprovoked. Minimum 3 months. DVT is caused by a transient provoking factor. At least we should give 6 weeks of treatment. Very important. Very important. Okay. No, I have not yet asked about distal. Okay. Wait. Okay. Next thing. We have to know something else. We know there's two different types of DVT, proximal DVT and distal DVT. So, how we categorize these proximal and distal DVT according to the location, right? So, what is the cutoff mark? Cutoff place? Knee, right? Knee, right? Okay, above knee is, we call it proximal, right? Below knee, we call it distal. So, what is the highest risk one? Is it distal one or proximal one? What is the high risk DVT from this proximal and proximal one, right? Why? What is the reason why this proximal one is more riskier? Why? You need to give me the example. Okay, closer to what? What, Dr. Awaf? Closer to what? Me? Yeah, you need to give a proper answer, right? Yeah. Yes, yes. Mm-hmm. Yes, yes. Good, good, good. Yes, go closer to other organs, right? It can easily can transfer to other organs, and especially can have like pulmonary embolisms because it's near to other organs. Like the lower knee is distance, right? Yeah. Okay. Now tell me, for proximal DVT, what is the time? What is the time? Proximal one. Proximal one. Mm-hmm. Proximal DVT. Here, proximal DVT. Here, usually 3 months. Okay, you can remember at least 3 months. At least 3 months. Proximal DVT. Okay. Then for distal one, how long? For distal DVT, 6 week, right? 6 week, right? Yes. Mm-hmm. Minimum 6 week. Okay. That's all for the treatment and everything. Okay, we will discuss here. So, yeah, VT prophylaxis later. Before that, we have discussed about pulmonary embolism. Pulmonary embolism, right? Okay, let's go to pulmonary embolism. Okay, what is pulmonary embolism? It's a blockage of pulmonary artery caused by blood clot, right? Travel to the lung usually from DVT, right? So we have risk factors. We have hereditary risk factors: antithrombin deficiency, protein C deficiency, protein S deficiency, right? Then acquired one fracture, so hip or leg, like same thing. This also have the same thing, right? Then moderate acquired or moderate. These are the strong risk factors. These are the moderate one. Surgery with general anesthesia less than 30 minutes. Chemotherapy, pregnancy, you know those things, right? The weak one. Yeah. Okay, so diagnosis. How we should diagnose these pulmonary embolism? Now tell me stepwise. Okay, I'm giving a scenario. Patient is presenting, there's a patient presenting with some shortness of breath, and then as the first thing, what you can do? Patient is presenting with shortness of breath only. What you can do as the first thing? As a first thing, what you can do. Mhm. Yes, if the patient is having chest pain or everything, then you have to do the ECG. But if the patient is presenting with only shortness of breath, you have to ECG also, because atypical presentation can be present. But mainly remember, like when we consider this pulmonary embolism, we have to do the chest x-ray as well, like initially. Why? Because we have to rule out other lung pathologies, right? Initially other lung pathologies we have to rule out. Anyway, we have to, like, if there's something related to chest pain or shortness of breath, we have to do the ECG as well. But remember, especially shortness of breath, chest x-ray is main thing, right? Very important initially. Okay, chest x-ray. Now next thing. Okay. Then we have different types of imaging for these pulmonary embolism. What are those types of imaging in pulmonary embolism? We have the main two things: SVQ scan and CTPE, right? CTPE. So, do we have any well score for pulmonary embolism? Do we have any well score? Yes, right. So here also we have to first decide, are we doing imaging for this patients, like specific imaging for this patient is not, or patient need or not. For that we have what? We have Wells criteria, and we have simplified Wells criteria, and we have the PERC rule, right? So let's see what is simplified Wells criteria. So here, clinical signs and symptoms of DVT. If patient present with DVT signs, patient get +3. If pulmonary embolism, most likely diagnosis +3. Heart rate more than 100 beats per minute, 1.5. Immobilization at least 3 days or surgery within past 4 weeks, 1.5. Previous DVT or pulmonary embolism, 1.5. Hemoptysis, 1. Malignancy treatment within 6 months or palliative, 1. If this patient is getting well score more than 4, that we are thinking this is like PE likely. This is PE likely, pulmonary embolism likely, right? Okay, here. First, we had to perform the well score. If pulmonary embolism likely, then we can go with the imaging, right? Okay, if pulmonary embolism unlikely, if it is less than 4, then you have to apply this PERC rule. So, what is PERC rule? PERC rule means age less than 50, pulse less than 100, SaO2 saturation more than or equal to 95, no hemoptysis, no estrogen use, no surgery or trauma, no prior venous thromboembolism, no unilateral leg swelling. How to remember these things, okay? If none of these present is no to any, then you have to go with D dimer. No to any, you have to go with D dimer. If yes to all, then no further investigation required, right? Because if we, yes to all mean age less than 50, pulse less than 100, no hemoptysis, no estrogen, like this PERC rule, like everything is fulfilled, yes to all, then no further investigation. So we have ruled out pulmonary embolism. If it is no to any, as example, if patient presented with hemoptysis, right? So we have to perform the D dimer in that case. So if it is positive, then we have to go with imaging, right? Hope you understand. Okay. So the next thing, the very important one, the treatment. Treatment is the most important next thing. So what is the treatment, doctors? Before the treatment, tell me, we have three types of pulmonary embolism. We have three types of pulmonary embolism. What are those? Tell me, doctors, what are those three types? We have massive pulmonary embolism, right? I have explained these things in our pulmonary embolism session. Okay, I have done a very good pulmonary embolism session in the beginning, I think December. What are the types of pulmonary embolism? Is there anyone? Anyone can tell me types of pulmonary embolism? Seems like you have not revised the theory. We have what? We have massive pulmonary embolism, then we have submassive pulmonary embolism, and we have low risk pulmonary embolism, right? It's very important, okay? Because then only first we have to identify, then only we have to decide the treatment, right? Massive, submassive, and low risk, right? Okay, anyway, initially, in pulmonary embolism patient, anyway, we have to stabilize the patient, right? If patient need oxygen, we have to give oxygen. Then, okay, then we'll go one by one. So if it is a high risk massive embolism. Okay, before that, sorry, 1 minute. Yes, that's the thing. Okay. If it is high risk or massive pulmonary embolism. So how we categorize it as massive one? Tell me. Massive. So what are the features that we can consider it under massive? Why we are telling it's a massive one? Quickly, doctors. Tell me, doctors. Doctors. Okay, what are the features of massive pulmonary embolism? Because in the exam, you need to identify which type of pulmonary embolism is this, right? Patient is having unstable features, right? There can be hypertension, this tachycardia, hypoxic, unstable, right? Patient presenting with those features. Patient is unstable. If the patient is unstable, you have to you have to think about this massive pulmonary embolism. Initially, what we can do, we have to consider thrombolysis with IV heparin. Thrombolysis with IV heparin. Thrombolysis, very important. Thrombolysis, okay, very important. With IV heparin. When the patient shows the persistent shock or sustained hypotension, avoid thrombolysis if the patient is having a major bleeding risk. So the thrombolysis cannot be used. Surgical or catheter detected or clot removal may be needed, right? This is from Australian guideline. I have shared this one as well in our group. I think in the beginning, I start this group at the end of the I think December. So if you can go and find out it, okay, the same thing, okay here. So what is intermediate risk? Here, intermediate risk, what we have to do? Intermediate risk, how patient presenting with? Patient is hemodynamically stable. Hemodynamically stable. Then what is the criteria that we call submassive? Tell me, doctor. Tell me, doctors. If the patient is okay, patient is stable here, but patient presenting with some heart problems, right? Patient presenting with some heart problem. The blood pressure is normal. Blood pressure is normal, but patient presenting with either right ventricular dysfunction, right? Right ventricular dysfunction. As example, some ventricular dilations, right? Then another reason the patient is having increased top troponin or BNP, right? BNP. Or patient is some associated with some other ECG changes like bundle branch blocks, right? Like something related with the heart, right? If these kind of features present, we call it submassive. In this case, these patients are stable. Because of that, we can start with the anticoagulations, right? Anticoagulation. So here, recommended management is intravenous heparinization here. Right, doctor, recommended one is initially start with the intravenous heparinization. So systemic intravenous thrombolysis is not recommended here. No need of thrombolysis, right? Yeah. Okay, then low risk one doctors here. But we can give manage with oral anticoagulation along is enough here. Oral anticoagulation is enough here. Blood pressure normal, the right ventricular dysfunction is known, but patient present with pulmonary embolism, right?
without any other risk factor. So we call it low risk pulmonary embolism. In that case, we can use DOAC, right? We can use oral one, right, doctor? So very important, right? Very important. So we can use oral one, right? Oral and anticoagulations, right? Same thing, everything mentioned in the therapeutic guideline. Okay. Okay, we'll do some question. And then you need to know the duration of anticoagulation. So 3 to 6 months for all initially, then stop 3 to 6 months if provoked by major reversible factor. Then indefinite therapy recommended for two or more unprovoked VTs, active cancer, antiphospholipid syndrome, or first unprovoked VT, decision based on the recurrence risk and everything. Okay, but I have never seen they ask it, but remember initially everyone need 3 to 6 month anticoagulation, right? Yeah, same. Another thing. Okay, I want to show something. Okay, this one. So here you have to diagnose it and tell me. Okay. So 40-year old woman present to the emergency department, sudden onset shortness of breath and chest pain 4 days after an elective gastric resection carcinoma. The pain is on the right side and her chest worse with the inspiration. She has no significant medical history and take no regular medications. Examination she appears distressed. Pulse rate is 120, BP 98 by 60. Respiratory rate is 32. Then SpO2 84. Jugular venous pressure is elevated and heart sounds are normal. Chest examination reveal reduced air entry in the right side. Initial troponin is 85, increased right. ECG shows sinus tachycardia with right heart strain. A CT PA is performed. So what is this? Is it massive, submassive, or low risk? Okay, so what is the treatment? What is the treatment option? What is the treatment option then? What is the treatment option then? Okay, why this is massive doctor? There's no name. Why massive? If the patient is present in with shock, no, right? Blood pressure is 98 by 60. This patient is not unstable, right? This is submassive, but you can see something else. Troponin is increased, right? There's some effect on the heart, right? And here they have telling tachycardia is normal for pulmonary embolism, but with the right heart strain, right? Something with heart and patient with pulmonary embolism. This is submassive when you can start the IV heparin, right? Here, low molecular weight heparin you can give, right? Your low molecular weight heparin. Mhm. No need to say sorry, doctor. Just learn these points, okay? Because I'm asking, then you never forget these points. Like if you have done a mistake, then only you learn, right? You learn something, right? Yeah. You no need to say sorry, okay? Yeah. Okay. Then another one. Okay, what about pregnancy? Okay, then tell me when we discuss about the when we discuss about the 1 minute bodies. Not this one. Just give me 1 minute, doctor. I want to show something because I have explained about pregnancy part during our recall session. Doctor said, tell me when to use CTPA and when. So what is the first line? Okay, compare CTPA and VQ scan. When to use? I'm at the same time I will find that part. Oh, there are so many recall files. I don't know how to find. March day one. Okay, found. When legs swelling and ears and symptoms that. Okay. What do you know about the what do you can okay, I'm asking a question. Can we do CTPA during the pregnancy? Can we do CTPA? Yes. When? So what is the indication? Okay, I'll show. Okay, this is day one recourse. This is day one recourse. Okay, doctors. And day one, we didn't get the pregnancy part in March, but I have explained that part as well. And the doctors have got it in day three, pregnancy part. Okay. You need to know two things. Okay, emergency also, they are doing some weird thing. Okay. They have two things. Two pulmonary embolism questions, pulmonary embolism question, two pulmonary embolism question. Okay, one is they preferred VQ scan, another one they have preferred something, not CTPA according to some other factors. So here, okay, mm, 1 minute. Okay, this question. Okay, this is the one. Okay, you need to know. Like, don't confuse. Okay, there's a two emails question. We are following most recent edited one because this is last reviewed 3 weeks ago, and the next question. Okay, this question last reviewed 4 months ago. Okay, this question they got VQ scan. In this question they got CTPA. So we are taking uh, personally, I'm taking this question, most updated one for my theory. Okay, most updated one for theory. So usually and previously we have learned like even though CTPA, VQ scan both having some radiation risk, we are going with VQ scan, right? Because in previous question, the one 4 months ago updated here, they have clearly mentioned that here. Okay, I'll show. Here, this question, they have clearly, 1 minute. Here, VQ scan is preferred investigation for suspected pulmonary embolism in pregnancy. But please, if you see this question, just forget it. Okay, this is the not old, but emergency also have something new. This question is very good and they can learn so many things. Okay, we'll do this question, then you will understand. A 35-year-old previously well woman, 34 weeks pregnant, present to the emergency department for rural hospital with 6 hour history of sudden onset shortness of breath, chest pain and cough. She's G1, P0, takes pregnancy multivitamins only and has had an uncomplicated pregnancy so far. So on examination, she appears unwell. Her pulse rate is 110, BP 90 by 60. Respiratory rate is 24, SpO2 88, then temperature 37.5. The rest of examination is unremarkable with abdominal signs consistent with her gestational stage. So ECG shows sinus tachycardia and T-wave inversions in lead 1 to 4. Lead 1 to 4, 2 and 3 and AVF. The chest X-ray shows bilateral blunting of the claustrophrenic angle. She is given supplement oxygen and intravenous fluid with clinical improvement. Repeat observation shows the blood pressure 115 by 70, heart rate is 95, SpO2 96 on 4 liter oxygen via nasal pump. They are asking which one of the most appropriate next investigation. Now tell me why they have chose CTPA over this VQ scan. Why? What is the important factor you can see in this question? Okay, what about other doctors? Mm-hmm. Yes. Chest X-ray, right? Okay, here. The patient present with the symptoms and signs suggestive pulmonary embolism. We know that. Then the ECG present on shows sinus tachycardia. Sinus tachycardia showing is normal for pulmonary embolism. It's a common ECG features in pulmonary embolism, right? The T wave inversion in the right pericardial and inferior leads indicate right ventricular strain, commonly associated with PE. In pregnancy, so, suspected PE commonly evaluate with either CTPA or VQ scan. Contemporary Australian guidelines recognize both acceptable as first line option with no single uniform preference. So choice should be individualized considering the hemodynamical stability of the patient. So chest radiograph findings, local availability and expertise. So radiation dose optimization and contraindication to iodinated contrast. So, although there are concern about radiation exposure during the pregnancy, the benefits of accurate diagnosis and prompt treatment outweigh the minimal risk. As the guide, VQ delivers higher fetal radiation dose 0.1 to 0.4 compared with CTP, compared with Q only or CTPA. So potentially uh, increasing the lifetime risk of childhood cancer slightly. However, CTPA delivers significantly higher radiation dose maternal breast tissue compared with VQ scan, which may increase the lifetime risk of maternal breast cancer. Decision making pathways are available for choosing the most appropriate imaging modality for in a given case. So, patients who are hemodynamically unstable and who fail to respond to resuscitation measures, imaging using either CTPA or scintigraphy VQ is not immediately appropriate. In such case, bedside echocardiography may be used to confirm the right heart strain suspected on ECG and if the present treatment commenced immediately with CTPA performs on the patient is stable. So remember this point as said. However, this patient, despite being hemodynamically unstable at presentation, has stabilized adequately for the image study, right? Because the patient is already given IV fluid resuscitation and now patient's BP is 115 and 70. Now we can do some imaging, right? Patient now in a stable situation because of this patient is presenting with 90-60 initially massive pulmonary embolism and they have stabilized the patient, right? They have stabilized the patient and now we can do the further imaging, right? Okay, here. So yeah, so have stabilized adequately for the image study. Therefore, in this case, CTPA is preferred modality. CTPA is used preferentially to a scintigraphy for diagnosing PE and hemodynamically unstable patient in patient where the chest radiograph is abnormal or when BQ scan is unavailable, all of which likely apply in this case. So CTPA is chosen as it allows detailed image of the pulmonary arteries and can directly visualize the thrombus, which is crucial for immediate management. And it is also superior for identifying alternative pathologies such as consolidation, which present in 60% of cases, right? So it's worth noting that this patient's presenting in her third trimester and risk of radiation to organogenesis is low, right? So radiology across border pulmonary embolism online resource as is the one they are using. Okay, right, doctors? Here, so when to use this Q scan or VQ, a stable patient when the chest radiography is normal and there's no alternative diagnosis is suspected, right? Have you got it? Have you got it or not? Okay, we have to consider things. This is for pregnancy. Okay, leg symptoms is anyway, I'll explain this part later. Okay, so here, patient presenting with pulmonary embolism symptoms without leg symptoms, so chest x ray. If it is normal, then can go with simply VQ scan. If it is abnormal, we can go with CTPA, but you have to think about the hemodynamically stable. If it is unstable, also we can go with CTPA, right? So remember those points, very important, right, doctors? Very important. Okay, then the next question is if a pregnant, you have to consider about the pregnant and non-pregnant. If a pregnant patient presenting with these pulmonary embolism symptoms like and chest pain and chest pain with this swollen leg, then what we can do, doctors. Okay, if you have no idea, please take a screenshot of this. Okay, take a screenshot of this. Please take this one, and please take a screenshot of this question as well, because very important. I don't know, like quickly you can find it, like take this one as well, because you need each details, because now AMC is not easy, right? You need to prepare very clear. You need to consider these tiny details, right? Those are the things they are more considered, because the competition is very high now, right? That's why AMC standards are getting higher. So these are very important points, right? Right, doctors. So I hope everyone took this screenshot. If you haven't take it, just ask in the group. I will share it. Okay, so don't worry. It doesn't matter. This is my record file. I don't care. You can ask me. Okay, I can. It's actually okay to share a screenshot of it. Okay, yeah. Okay. Yeah, yeah, doctor. I will upload it. Don't worry. If the patient is stable. Okay, okay. Non-pregnant later. Okay, doctor. Now we are discussing about pregnant, right? I saw your previous you have discussed you have sent that something about like selling and in non-pregnant patient in our chat. Okay, I will explain, because I saw like you have done some mistake in that case. Okay, next question. Patient is having pulmonary embolism symptoms like with chest pain or shortness of breath. Then the patient is presenting with the swollen leg as well. In that case, are we going with what? I'm giving options: CTPA. Dr. Turkia, you should be now you have be full aware of these questions and theory. I have explained multiple times during our recall sessions, right? You were from the beginning. You don't have any confusion, right? Yeah, because these things I have explained multiple times. Yeah, it's fine. I'm just kidding. Okay. uh, you have to clear the concepts. Okay, you have getting DVT. Sorry, you have getting a swollen leg with pulmonary embolism features. Then the investigations are CTPA, VQ scan. Then you have duplex ultrasound. So what is the one you are choosing here? What is the one you are choosing here? Duplex. Why? Now tell me why duplex. Why we are not going with yes leg symptoms, right? But you need to why? Okay, give me the reason why. Patient is having actually not only the thing is fast. Actually, the thing is this. Okay, patient is pregnant mean patient is high risk for the radiation exposure, right? High risk for the radiation exposure. So if the patient is having some leg swelling, then we already know, right? The most commonest cause for pulmonary embolism is having a DVT, right? If we find out if the patient is having this unilateral leg swelling and it seems like a DVT, so we have to first do the duplex. It's a non-invasive and there's a no radiation for that, right? For pregnant patient, if we find out this patient is having ongoing DVT, we can start the anticoagulation immediately, right? Then we don't need to do other investigations like radiation exposed investigation. We have already started the treatment, right? Then we know, right? DVT is the cause. DVT is the main source of this pulmonary embolism. Then anyway, we can start the treatment, right? So we don't need the unnecessary radiation exposure for this mom and baby, right? Mm-hmm.
Okay, right. So the next question, if a non-pregnant patient presenting with, okay, there is some Lexedin as well, and but more prominent with the chest symptoms. In that case, what we can do? Mm-hmm. But we are given in pregnant patients, molecular weight heparin, right? You're asking. Okay. Okay, here. This is the question. Okay, we'll do this question. 1 minute. I think this is. No, this is not the question. This is 1 minute, doctors. Okay, this is the question. Okay, 76-year-old woman present to the emergency department with shortness of breath has progressively worsened over the past 2 days. She does not have cough, hemoptysis, or chest pain. She's a medical history. She has a medical history, stage 4 breast cancer, palliative chemotherapy, and chronic kidney disease with estimated glomerular filtration rate 46, and medical medication include letrozole, paracetamol as required. She has 42 pack years smoking history and no travel history. Examination, examination, doctors. There is appears unwell, pulse rate is 110, and regular blood pressure 130, 134 by 90, respiratory rate 22, SpO2 94, temperature 36 point, and there's erythema of her leg, lower leg, which is tender on palpation. Auscultation of the lung reveal bronchovascular breath sounds with no adventitious sound. ECG is here. ECG is here. Which one of the following is most appropriate diagnostic investigation? What about other doctors? Okay, here. Here, the most likely etiology for this patient dyspnea is pulmonary embolism. this is supported by the. This is supported by 1 minute. Supported by her old age, active malignancy, treatment with chemotherapy, and all which place at high risk, right? So CTPA is a gold standard for diagnosis pulmonary embolism capable of visualizing emboli down the sixth generation branches of the vascular area. Although this patient has CKD and EGFR 46 and contrast induced nephropathy at this level of renal function is low and can be further reduced with prehydration. Alternatives, the CTPA are generally considered with EGFR falls below 30, right? Then when below 30, through even severe renal impairment remains a relative rather than a absolute contraindication when clinical suspicion is high. So why not VQ? Consider second line, right? Second line. With that, here also there are some leg symptoms was present, right? So here, the erythema of lower leg and with tender and palpation. There can be some leg symptoms, but it doesn't mean that we are going with ultrasonography. Sorry, duplex ultrasonography, right? In those cases, we have to give prominent because these are non-pregnant patients, right? Non-pregnant patient. Then these cases, you have to give priority to the chest symptoms, right? You can do the CTPA or VQ scan, but first line is always CTPA in non-pregnant patient, right? I hope you understand these points, right? In pregnancy, it is different, and pregnancy, it is different. But in the non-pregnant, it's something different, right? You need to make a small note, right? Small note for all these cases. Then only you will understand. Otherwise, now you can understand, but tomorrow it will be forgotten, right? I doctors, okay. Okay, now doctors. Okay, what we can do? Okay, we have this part, right? Okay, we have this part, prophylaxis part. Okay, quickly go through this one. Okay, we'll discuss about prophylaxis part. This is for both BT prophylaxis for pulmonary embolism and DVT both. Okay. So you all know what are the risk factors, right? So risk factors for BT in non-surgical patients, advanced age 60 or more than 60, obesity, recent trauma or surgery within 1 month, prior VTE, non-thrombophilia, active cancer, these things. Okay, heart failure. I'm not going to read everything, but mainly you should know about the major risk factor is a surgery, right? One of major risk factor is a surgery. So here, assessment of need for VT prophylaxis in patient admitted to hospital. The harm benefits balance for risk of bleeding and thrombosis must be weighed up individual, right? Aim to avoid dehydration and start mobilizing patient as soon as possible. The relative risk of bleeding or VT can change the duration of patient admission to the hospital because of the evaluation of the disease and interventions that may be carried out. To ensure optimal VT prophylaxis, you have to reassess within 24 hours of admission whenever their condition change and at least every 7 days, and the transition of care. Very important, doctor, right? You have to reassess it, patients, right? Okay, so these are the risk factors they are explaining. Then we have to approach the VT prophylaxis here. So, 1 minute. What is this fact sheet? No, this is not for us. Okay, here. So we have two things. I'm explaining simply. We have two things: pharmacological prophylaxis and we have mechanical prophylaxis, right? Pharmacological one and mechanical prophylaxis, right, doctors? Mm-hmm. So we all know what are the pharmacological prophylaxis, right? Low molecular weight heparin, right? Unfractionated heparin, right? Fondoxifarine, those things, right? And uh, DOACs, right? We know like we have pharmacological and non-pharmacological one. Okay, I'm not going to discuss about it. Then we have mechanical one. What are the mechanical one? We have intermittent pneumatic compression device, pneumatic foot compression or pump, right? We have compression stockings, right? Those are the mechanical one, right? Okay. So, what about VT prophylaxis in non-surgical patients? The choice of VT prophylaxis in non-surgical patients in hospital depend on the assessment for patients' risk of developing VTE weight against their bleeding. So here, medical condition leading, we know, right? What are the medical condition that here? You need to consider these things. Ischemic, if the patient is okay, just remember these tables that only for the indications. Conditions increasing the risk of VT. Ischemic stroke with immobility. So prophylaxis and duration depending on the degree of immobility. Consider low molecular weight heparin or unfractionated heparin continuous until the patient is mobile or discharged. Or IPC, and the mechanical one continue up to 30 days or until the patient is mobile or discharged, right? So if the patient is a heart failure one, we can give low molecular weight heparin or unfractionated heparin until patient mobile or discharged. Active cancer, uh, I'll explain. It's not very important. Important, like here, but here, okay, we'll go through this one. It also depending because cancerous patient also having the surgical patients and non-surgical patients, right? Because we all know some patients is going undergoing surgery for the cancers, right? Okay, here in that case we have to first risk assess this patient, right? We have this there's a score called coroner score. So this we should be assessed to VT risk assessment before starting the cancer patients prophylaxis. So here VT prophylaxis is appropriate. Consider low molecular weight heparin or apixaban or rivaroxaban, right? So continue pharmacological VTE for patient with active cancer at least until hospital discharge. It may be continued for longer depending on the VTE risk and determined by the specialist. Prolonged prophylaxis is recommended for patient undergoing abdominal or pelvic surgery for active cancer. Here they have
explain this part in another table. Okay, so don't worry. Okay. So another one, pregnancy and childbirth. That's another thing. Here, pregnancy and here also we have to assess the risk. Here, assess the risk. Okay, we know these patients are like already risk patients, but another again we have to assess it. Pregnancy and postpartum period are risk factors of development of BTE. Then which is important to cause the maternal morbidity and mortality, although the risk of VT pregnancy is 4 to 5 times greater than the risk of non-pregnant patient. The absolute risk is low. Incident to VTE on or 2 per thousand pregnancies. Assess the patient for risk of VTE in the early pregnancy or pre-pregnancy. A table of VTE risk factors in pregnancy and immediate postpartum period. Yeah, no need, just no need to go very in deep. Okay, if prophylaxis is not required on initial assessment, continue observe patient for possible signs and symptoms of VTE throughout the pregnancy. Okay, the postpartum period and the postpartum period also reassess the patient if they develop complication during the pregnancy and are admitted to the hospital. Okay, they may require VTE prophylaxis while in hospital. Like if they want to ask about VT prophylaxis, they will give a good scenario. Okay, they will give a good scenario with past history of DVT, like something with some high risk factors. Okay, so limited evidence suggests that risk factors for VT are synergistic. Synergistic. Only patient with additional risk factors for VT other than pregnancy require prophylaxis. Okay, here most common risk factors that warrant VT prophylaxis of pregnant history of prior hormone associated VT, especially the history of prior unprovoked VT, the presence of high risk hereditary thrombophilia, or if the patient is having some thrombophilia history, right? Yes. So drug therapy. If VT prophylaxis is given, we have to give low molecular weight heparin or unfractionated heparin, right? Right, doctors here? So we have to go low molecular weight heparin, all these things. And what about, yeah, okay. But in case of active GI cancer, we use yeah, doctor, we are using low molecular weight heparin. They have mentioned it. We just discussed, right? Here. Okay, they have given like everything here. Mm-hmm. In active cases, most of the time we are going with um, the low molecular weight to IV heparin, right? So this is not the very important part. The important part is the surgical part, okay? It's also important, but this is the most important part. Very important. You need to remember everything. Yeah, if there's a total hip rip, this is not hard, okay? This is the surgical part. This is not the hardest. Just remember, if total, both or one. Like, remember like this. Here, okay, Alex, when total hip replacement, a DWAC. A DWAC or low molecular weight heparin fondoxipine continues for 28 to 35 days with gradual compression stocking or IPC4 foot pump until fully mobile. So you have to think about like if total hip replacement, just remember mechanical and pharmacological both, then mechanical for 28 to 35 days, mechanical for until patient is mobile, right? Is it not hard, right? So if it is a total knee replacement, so anticoagulation, we have to give pharmacological for 10 to 14 days with non-pharmacological or mechanical one here until patient is mobile. Okay, if a hip fracture surgery present, we are giving low molecular weight heparin or fondoxipari 28 to 35. If it is a like high risk surgery, you have to give like more low, like 28 to 35 days, like that. Here pharmacological prophylaxis is contraindicated. Here we are using these foot pump and like mechanical one. Otherwise, in hip fracture surgery, the pharmacological one is enough, right? They are not giving plus, they're just giving They are suggesting pharmacological, it is contraindicated only. We are going with mechanical, right? Major surgery like abdominal or gynecological or cardiac, thoracic or vascular surgery. Then here also we have to use both. Here continue up to 1 week or until fully mobile plus this mechanical one for until patient is fully mobile. So here transurethral resection of the prostate or radical prostatectomy. Here, IPCO gradual compression stocking for patient. Usually, the mechanical one is enough, but if the patient is having high risk for VTE, then we can consider about giving these anticoagulation drugs, right? Right, doctors, anticoagulation drugs. So, neurosurgery. Here also, the mechanical one is enough, but patient is having a high risk factors for VTE, either pulmonary embolism or DVT, then we have to consider about giving pharmacological therapy. So trauma, for admission, we have to give a mechanical one, foot pump with consider low molecular weight heparin when bleeding risk become low, right? For cancer patient having general abdominal, pelvic or neurosurgery here, can you see low molecular weight heparin, no unfractionated heparin, depending on the bleeding risk, right? Continue at least 7 to 10 days post-operatively. Consider 28 days for low molecular weight heparin patient having major abdominal or pelvic surgery for cancer. If pharmacological is contraindicated, we can use this mechanical, right? Otherwise, pharmacological is only enough, right? So, C-section. Low molecular weight heparin for 5 to 7 days after delivery or until fully mobile, following emergency section, elective C-section with mechanical one, right? It is harder, so then you need to know something else about Caprini score, right? Do you remember about this Caprini score? 1 minute. Okay, what do you know about this Caprini score? Tell me about this Caprini score. So basically, we are using this Caprini score for surgical patients, right? For surgical patients, right, doctors? So this Caprini score for venous thromboembolism for pulmonary embolism and DVT help to determine the need for VT prophylaxis in hospitalized surgical patients. It can be calculated using this table. I know this is hard, but you have to somehow remember. At least remember something. At least remember something like the general things, the age, and what are the what are the minor surgery, what are the major surgery, right? You need to have an idea, right? Another nightmare. Yeah, doctor. So here, so you should know, like, because if they have given some scenario, you need to calculate it. But it's not a very hard one. You need to identify the ages, right? Age, if it is 41 to 61 point, if it is 61 to 74, 2 points. Just remember 40 to 60, 1 point, then 60 to 75, 2 points, then so on 75, 3 points, like that. Okay, after 75 you are getting 3 points. If it is a minor surgery, the 1 point another criteria, one minor surgery, that means less than 45 minutes, and less than 45 minutes, you are getting 1 point. History of major surgery, okay, longer than 45 with the last one, history. So, varicose vein, history of IBD, swollen leg, obesity, BMI more than, especially the BMI is very important, remember. BMI is more than 25, that also 1 point. Sepsis within last month, serious lung disease, abnormal pulmonary function, then currently at bed, oral contraceptive replacement therapy or hormone replacement therapy, pregnancy or postpartum less than 1 month. So history of unexplained stillborn infant, recurrent spontaneous abortions, 3 or more, premature birth with tanexemic or growth, like that. Okay. So remember. Then next 2 points, arthroscopic score, malignancy, major surgery longer than 45 minutes. Then, mm, yeah, doctor, anyway, you have to
you have to just take this picture and make a small version of like how you can remember, right? Like when we consider this one, you can severely like not severely, sorry, you can consider about, can you see here in this part, they are they are having the risk factors, the main risk factors for this DVT and pulmonary embolism, right? The swollen leg, right? The symptoms as well. Then obesity 25, right? Then some heart failure features, sepsis, right? The minor surgery, right? Like that. Then 2 points is major surgery, more than 45. The malignancy, right? Present or previous. Then arthroscopic surgeries, right? Confined to bed at least 72. Immobilized in plaster cast less than 1 month, like that. 3.75 year. History of DVT and PE. And then family history of thrombophilia, right? Positive factor V lesion, positive prothrombin. These are mostly with thrombophilia things and history of DVT and PE, right? So elevated anticardiolipin, heparin-induced thrombocytopenias, right? Congenital thrombophilias, like those are getting 3 points. Then 5 points. Hip pelvis or leg fracture within last month, because you all know hip, pelvis, and this knee surgeries. These are very high risk, right? So they will get 5 points like that. A stroke within last month, multiple trauma within last month, acute spinal cord injury, like that. So according to the here adding total points from the all column, then we have to take here if the patient with total swollen leg with obesity 2 points, and patient is more than 75, then you can take 3 points, then you can you have to get the sum of all of this as 5, right? That is the total score. And according to the total score, if total score is 0, VTE risk is very low, right? Then no VTE prophylaxis. If it is 1 to 2, if it is a low risk for this VTE. So in that case, VTE prophylaxis, but mechanical one is enough. Then if it is 3 to 4, it's a moderate risk, right? Then VTE prophylaxis, the pharmacological and or mechanical. Okay, then 5 or more high VTE prophylaxis need both mechanical and pharmacological, right? Do you want? I know this. You have to buy hard. You have to buy hard. Remember this one, because this time they have asking from this one. The multiple questions asking from this part, right? Okay, we'll do one question. Okay, tell me the answer for this one. A 35-year-old man presented to the GP clinic for pre-operative assessment. He's scheduled for elective repair of the right inguinal hernia next week. He has a medical history of GERD and hypercholesterolemia, but is otherwise in good health. He does not take any regular medications. He is a non-smoker and drinks about 1 glass of wine a day. On examination, he appears well with vital signs within normal limit, BMI 28. Physical examination is otherwise unremarkable. Some consideration must be given to prophylaxis agent, venous thromboembolism. He will wear graded compression stockings and there will be an intraoperative pneumatic calf compression. Which one of the following is most appropriate additional measures for thromboprophylaxis? What do you think? What about other doctors? Mm-hmm. Okay, here. Answers no additional measures. The patient considered low risk for venous thromboembolism based on the Caprini score, which is the yeah, sorry, most widely utilized the validate for VTE risk assessment model for surgical patients. This in this case, no additional measures beyond the planned mechanical prophylaxis are necessary. The Caprini score consider various risk factors, the same thing that we have just discussed. Interpretation of Caprini model is as follows: very low risk 0, low risk 1 to 2 points here. Moderate is 3 to 4 points. High is more than 6, right? Sorry, more than 5 points. 5 or equal to 5. I hope you understand this Caprini score and everything. There are some questions in A medicine you can do and get a more idea, more information. So I hope everything is clear. Yeah, we have done almost 4 hour class. Now I think we can stop it, right? Yeah, yeah, no, you need to revise it and you need to practice. Like you can make a scenario uh by yourself, then you can decide. Like you can write down a scenario, then you can practice, right? What is the Caprini score, like that. Right? Yeah, sure, doctor. Once the like converting part is done, I will upload. It will take around 1 hour to convert from Zoom into my laptop. So after that, I have to upload, and it also will take time around like 3 to 4 hours. I will upload it. Okay. Okay, sure, doctor. I will continue tomorrow and day after tomorrow as well. Yeah. Yeah. Thank you so much, doctors. Mm-hmm. Okay. And like exam week recall classes, the registration is closed on this Friday, doctors. If someone want to join before Friday, you can send me a message. Okay, thank you so much, doctors, because some doctors are asking about the exact date. So the registration is closed on this Friday. Okay, for the exam week recalls. And thank you so much, doctors. We will meet tomorrow and let's see what we can do, right? Okay. Like if you have any suggestions, just give me the names, okay? Because actually the topics, because actually I don't have time to go through those files and find it out. Okay. Thank you so much, doctors. Okay. Then we will meet tomorrow at the same time. Okay. Have a good day, doctors. If you have not yet joined the April group and the May group, please send me a placement letter. Then I will add you to those groups. Okay? Because like when monthly exam is coming, I'm always giving priority to those doctors because they need more priority. Because of that, it's better if you can add it into exact month. And next week, after exam week, I will make the June and July group as well. Then I will update. I will give a update in the group. Okay, then you also can join. Anyone can join. So have a good day, doctors. Bye bye. Study well. You can do this. Okay. Yeah.